This is Dr. James Hutcherson, and this is the presentation on the urinary system. So, the organs of the urinary system include the kidneys, ureters, urinary bladder, and urethra. So the kidneys filter blood and they form urine. The ureters transport urine from kidneys to the urinary bladder. The urinary bladder collects and stores urine. And the urethra conveys urine from the urinary bladder to outside of the body. Now, when it comes to the kidneys, they actually have quite a few different functions. They help with homeostasis, so it is an excretory organ. They maintain the composition, pH, volume of body fluids within their normal limits. The kidneys remove metabolic waste and substances present in excess, including foreign substances like drugs and the toxic metabolites from that. And they secrete hormones. They regulate specific metabolic processes. And this is an image showing you all of those major structures of the urinary system. Okay, do not confuse the ureters with the urethra. The urethra comes out of the bladder, the ureters come out of the kidneys. So kidneys actually do have color to them. They're a reddish brown color. They're bean-shaped organs and have very smooth surfaces. Of course, they're larger than a bean. They're about 12 centimeters long, 6 centimeters wide, 3 centimeters thick in most adults. And they perform several homeostatic functions for the body, as we mentioned. So more specifically, they regulate the volume and composition of body fluids. They remove excess water and electrolytes and metabolic waste from the blood. They excrete waste in the urine. They secrete the hormone erythropoietin, which stimulates red blood cell production. They secrete the enzyme renin, which helps to increase blood pressure. They produce active forms of the vitamin D, calcitriol, which increases calcium absorption from the small intestine when the blood calcium levels are low. And when the kidneys are not functioning properly, hemodialysis and continuous peritoneal dialysis can be used to filter waste out of the blood. The kidneys lie on both sides of the vertebral column in the depression on the posterior abdominal wall. They're considered retroperitoneal, which means they are behind the parietal peritoneum, the serous membrane. The left kidney is 1.5 to 2 centimeters higher than the right kidney because of the position of the liver. And the kidneys are surrounded by a fibrous renal capsule and adipose tissue we call renal fat, and connective tissue we refer to as renal fascia. And this image shows you the location of the kidneys. Kidneys have convex lateral surfaces and a concave medial surface. The renal sinus is a hollow chamber in the medial depression. The renal cortex is an outer region of the kidney. The renal medulla is an inner region composed of renal pyramids. The renal columns are extensions of cortex that dip into the medulla. The hilum is the entrance to the renal sinus. The renal pelvis is the funnel-shaped sac superior end of the ureter and includes the major and minor calyces. The major calyces are large tubes that merge to form the renal pelvis, and the minor calyces are small tubes that merge to form the major calyces. The renal capsule is a fibrous capsule around the kidney, and the nephrons are the functional units of the kidneys, each of which is a site of urine production. Okay, in this image, 20.4 shows you the kidney structure, pointing out those specific areas like the cortex, the minor and major calyces coming out of the pyramids, renal sinus, the renal columns, the fat that's in the renal sinuses, renal pelvis, renal papilla, the renal pyramids, and then the ureter. And on the right side here, you can actually see a close-up version of the nephrons. And we're going to talk quite a bit about that because that is the major functional unit of the kidney. Okay, major arteries of the kidney include the renal artery, which branches off the abdominal aorta. It enters the kidney through the hilum. It transports 15 to 30% of the cardiac output to the kidneys. Okay, the segmental arteries, they branch off the renal artery. The interlobar arteries, they branch off the segmental arteries. They flow between the renal pyramids. The arcuate or arciform arteries, they branch off the interlobar arteries and they arch around the renal pyramids. And the cortical radiate arteries, which branch off the arcuate arteries. In this image, figure 20.5 shows you the blood supply of the kidneys and the adrenal glands also. Okay, blood vessels within the nephrons. You have afferent arterioles, which branch off the cortical radiate arteries. Each enters a different nephron. The glomerulus, the capillary cluster that branches from the afferent arteriole, filters blood in each nephron. The efferent arteriole, which arises from merging of glomerular capillaries and transports blood that was not filtered by the glomerulus. The peritubular capillaries, these branch off the efferent arteriole and they surround the renal tubules. As far as the venous drainage of the kidneys, so from the nephron, blood flows into the renal vein and then leaves the kidney. The veins, so these parallel the arteries of the same name, the cortical radiate interlobular vein, the arcuate arciform vein, the interlobar vein, and the renal vein. And there's no segmental veins. And this image shows you the nephrons and the renal blood vessels, their relationship. This is a cast of the renal blood vessels. This figure shows you the blood vessels of the nephrons. Okay, so here's a flow chart of renal blood supply, starting with the abdominal aorta. Okay, it goes to the renal artery, the segmental artery, the interlobar artery, the arcuate artery, and then to the cortical radiate artery, which goes into the afferent arteriole. And then this enters the glomerulus. And coming out of the glomerulus, we'll have the efferent arteriole, which goes to the peritubular capillaries or the vasa recta, which then go to either the cortical radiate vein or the arcuate vein, then to the interlobar vein, then to the renal vein, then to the inferior vena cava, back to the heart. Okay, as I said, the nephron and the glomerulus, these are really the functional units of the kidney. And the nephron is composed of two parts, a renal corpuscle and a renal tubule. The renal corpuscle includes the glomerulus. So it has a capillary cluster. It filters blood to begin urine formation. And it arises from the afferent arteriole and drains into the efferent arteriole. The glomerular capsule, also known as Bowman's capsule, receives filtrate from the glomerulus. Now, the renal tubule extends from the glomerular capsule to the collecting duct. Filtrate proceeds from the glomerular capsule to the proximal tubule to the nephron loop, also called the loop of Henle, that has descending and ascending limbs, and then to the distal tubule. The distal tubules of several nephrons will then empty into a collecting duct, and the collecting duct continues through the medulla and drains through the renal papilla into the minor calyx. Okay, and this image shows you the structure of the nephron and the renal corpuscle. So the renal corpuscle consists of a glomerulus and a glomerular capsule that surrounds it. This is the site of blood filtration in the kidney. Notice the efferent arteriole here and the afferent arteriole here. So blood comes into the glomerulus through the afferent arteriole and leaves through the efferent arteriole. Figure 20.10 shows you the structure of the nephron. So again, here's the glomerulus, here's the glomerular capsule. Shows the afferent arteriole, the efferent arteriole. And notice coming out of the glomerulus and the capsule, we have the proximal tubule, then we have the descending limb of the nephron loop, the ascending limb of the nephron loop, which then goes into the distal tubule. Okay, ultimately, the distal tubule goes into the collecting duct. This is a microscopic view of the kidney, and you can see those glomeruli and the glomerular capsules. This figure shows you the sequence of structures in urine formation. So first, you're in the glomerulus, where you have filtration, goes to the glomerular capsule, then to the proximal tubule of the renal tubule, the nephron loop, the descending limb, and then the ascending limb of the renal tubule, then to the distal tubule, then to the collecting duct. And then this part we consider urine excretion. That first part was urine formation. After the collecting duct, you go to a minor calyx, then to a major calyx, to the renal pelvis, to the ureter, and then ultimately to the urinary bladder and to the urethra. There's two types of nephrons in the kidney. The cortical nephrons. This is the majority of the nephrons, about 85%, and they lie almost completely in the renal cortex. They have short nephron loops, and the renal corpuscles are located near the surface of the kidney. Okay, the juxtamedullary nephrons, this is about 15% of the nephrons. They have long nephron loops that extend deep into the medulla. The renal corpuscles lie deep in the renal cortex. These are important in regulating water balance and urine concentration. The juxtaglomerular apparatus is a structure that regulates the secretion of the enzyme renin. It monitors and adjusts blood pressure and sodium chloride content of the filtrate. It's found at the point of contact, where the ascending limb of the nephron loop passes between the afferent and efferent arterioles. At this point of the contact, cells of both structures are specialized. You have a macula densa, which are tall, closely packed cells of the ascending limb, and these monitor the sodium chloride content of filtrate. The juxtaglomerular cells are large vascular smooth muscle cells of the afferent arterioles, and they monitor the blood pressure. Okay, figure 20.13 shows you the juxtaglomerular apparatus. Okay, clinical application. Glomerulonephritis, which you may have heard of. So nephritis is an inflammation of the kidney, and glomerulonephritis is inflammation of the glomeruli, and it can be acute or chronic. In acute glomerulonephritis, this results from abnormal immune reactions. So 1 to 3 weeks after infection by beta hemolytic streptococci, this may occur. The infection does not start in the kidney. Antigen-antibody complexes form insoluble immune complexes, which lodge in the kidneys. And these complexes deposit in and they block glomeruli. In the chronic form, this is a progressive disease that involves prolonged inflammation. More and more nephrons are damaged until the kidneys cannot function. Fibrous tissue replaces glomerular membranes, and this disables the nephrons. Okay, let's talk more about urine formation. So urine is an excretory product formed by nephrons in a collecting duct as they regulate composition of the body fluids and remove wastes from the blood. Urine contains waste, excess water, and electrolytes. And there's 3 processes of urine formation: glomerular filtration, tubular reabsorption, tubular secretion. In glomerular filtration, this is performed by specialized glomerular capillaries at the first capillary bed. Water and small molecules are filtered. Filtered fluid enters the renal tubules and becomes tubular fluid. In tubular reabsorption, we have a transfer of filtered substances from the renal tubules to the peritubular capillaries, the second capillary bed. And it only reclaims useful substances, while waste continue to become urine. In tubular secretion, we have a transfer of certain substances from the peritubular capillaries to the renal tubules. This adds waste products and excess substances to the forming urine. Okay, figure 20.14 shows you the specialized capillaries of the kidneys. In most systemic capillaries, filtration predominates at the arteriolar end and osmotic reabsorption predominates at the venular end. In the kidneys, the glomerular capillaries are specialized for filtration. The renal tubule is specialized to control movements of substances back into the blood of the peritubular capillaries. So this is tubular reabsorption, or from the blood into the renal tubule, and that is tubular secretion. Okay, glomerular filtration. This is the first step of urine formation. Substances move from the blood into the glomerulus, into the glomerular capsule. Water and small dissolved molecules and ions can be filtered. Large molecules, such as large proteins, remain in the blood due to large size. Glomerular capillaries are much more permeable than other capillaries due to fenestry. These are tiny openings in the walls. Glomerular filtrate is formed as substances filter from glomerulus into the glomerular capsule. Filtrate has about the same composition as tissue fluid. The main force that filters substances through the glomerular capillary wall is hydrostatic pressure of blood of the glomerulus. Afferent arterioles have larger diameter than the efferent ones and others in the body. So resistance in the efferent arteriole increases the blood pressure in the glomerulus, and that favors filtration. So net filtration pressure is the force that favors filtration minus forces that oppose filtration. The force favoring filtration, this is glomerular capillary hydrostatic pressure. So that's basically blood pressure. Forces that oppose filtration include glomerular capillary colloid osmotic pressure. And that's because of plasma proteins in the glomerulus. And capsular hydrostatic pressure. As long as the net filtration pressure in the glomerulus is positive, filtration is going to occur. Okay, this figure shows you the filtration pressures. And as you can see, usually you have a net filtration pressure that is positive. Glomerular filtration rate. The kidneys receive about 25% of cardiac output. 20% of the blood is filtered by the glomerular capillaries. The average adult glomerular filtration rate is 125 milliliters per minute or 180 liters per day. Blood plasma is filtered at about 60 times per day. Only a small percentage of the filtrates actually excreted, though, as urine. Factors that affect glomerular filtration rate? Well, GFR is directly proportional to the net filtration pressure. So anything that changes the net filtration pressure will change glomerular filtration rate. Glomerular or capsular hydrostatic pressure, or glomerular colloid osmotic pressure. Changes in the diameter of the afferent or efferent arterioles also. Okay, this figure shows you the volumes of the glomerular filtrate versus the volume of urine. Okay, this is regulated, and there's different forms of it. In autoregulation, this keeps the glomerular filtration rate relatively constant. An increase in systemic blood pressure causes vasoconstriction of the afferent arterioles, and this reduces blood flow to the glomerulus, which decreases glomerular filtration rate, and this maintains kidney function. In juxtaglomerular apparatus and tubuloglomerular feedback, we have an increased glomerular filtration rate, which increases the amount of filtrate in the renal tubule. When excess sodium chloride reaches the macula densa and the distal tubule of the JGA, afferent arterioles are vasoconstricted. So GFR is decreased towards the normal range. Certain conditions may increase or decrease the glomerular filtration rate in order to maintain homeostasis, such as when GFR increases in response to excess body fluids. There's also hormonal control by the cardiac hormones. The heart secretes atrial natriuretic peptide, or ANP, and ventricular natriuretic peptide, or BNP, in response to increased blood volume and pressure. This increases excretion of sodium and water excretion. The sympathetic nervous system also exerts neural control over glomerular filtration rate. Sympathetic responses to changes in systemic blood pressure also affect the kidneys. When blood pressure or volume decreases, sympathetic stimulation causes afferent and efferent arterioles to constrict simultaneously. This maintains the GFR in the normal range. And then you have hormonal control via the renin-angiotensin-aldosterone system. This is also just called the renin-angiotensin system. It's activated by decreased blood pressure, sympathetic stimulation, or macula densa. A decrease in sodium chloride concentration will cause secretion of renin. Renin converts angiotensinogen to angiotensin 1, which is converted to angiotensin 2 by ACE. Angiotensin 2 causes vasoconstriction of afferent and efferent arterioles and secretion of ADH and aldosterone. This increases thirst and retention of sodium and water and blood pressure. Okay, this graphic shows you the control of glomerular filtration rate by changing the diameter of the afferent and efferent arterioles. This figure shows the renin-angiotensin system. Okay, let's talk about tubular reabsorption. This is the movement of useful substances from the renal tubules back into the blood of the paratubular capillaries. Most tubular reabsorption, about 70%, occurs in the proximal tubule, which is lined with microvilli. Different parts of the renal tubule reabsorb specific substances. Substances are transported by various methods of transport. Diffusion, which is passive transport of lipid-soluble substances. Passive transport is through the ion channels or carriers. And then osmosis. This is the passive transport of water, sometimes containing solutes. In active transport, we have the movement of substances across their concentration gradient, and it does require ATP, you might recall. Limited transport capacity is due to the number of carrier proteins. Each substance has a transport maximum, and it can only transport specific numbers of molecules in a certain amount of time. The renal plasma threshold is reached when there's more transported substances in the plasma than the active transport mechanism can handle, and then excess spills into the forming urine. Substances that are reabsorbed by active transport: glucose, amino acids, lactic acid, citric acid, and phosphate, sulfate, calcium, potassium, and sodium ions. And this figure shows you the three processes of urine formation: glomerular filtration, tubular reabsorption, and tubular secretion. Clinical application: the nephrotic syndrome, a set of symptoms that occurs in people with renal disease. Some renal disorders cause increased permeability of the glomerular membranes, which allows plasma proteins to enter the urine. The loss of plasma proteins into the urine causes widespread edema and increased likelihood of infection. Decreased concentration of plasma proteins decreases osmotic pressure, leading to edema, ascites, and fluid accumulation in several body cavities. Edema and other abnormal fluid accumulation leads to a decrease in blood volume and pressure. These events lead to activation of renin-angiotensin systems and ADH and aldosterone secretion. Kidneys conserve sodium and water, which restores blood volume, but makes edema worse. Get a little more detail on sodium and water reabsorption. About 70% of the sodium ions are reabsorbed in the proximal tubule by active transport. Sodium active transport provides energy and methods for reabsorption of many nutrients like glucose, amino acids, ions, vitamins, and water. The sodium-potassium pumps create gradients that provide for reabsorption by secondary active transport. So sodium diffuses down its concentration gradient. Other substances are co-transported by carrier proteins into the epithelial cells of the renal tubules. Glucose and negatively charged ions like chloride and bicarbonate are reabsorbed by this method. The process continues throughout renal tubules. 97 to 99% of the sodium and water are reabsorbed before excretion of urine. ADH increases water reabsorption, and aldosterone stimulates sodium reabsorption. Table 20.1 shows you your average values for sodium and water filtration and reabsorption and excretion. This figure shows you the points at which sodium and water reabsorption occur. Okay, tubular secretion. This is the reverse of tubular reabsorption. This is the movement of substances from plasma of the paratubular capillaries into the fluid of the renal tubules. Substances are derived from the 80% of plasma that is not filtered by glomeruli, like the waste and large molecules. Active transport mechanisms function in tubular secretion, but work in opposite directions as tubular reabsorption. Substances secreted into forming urine include drugs, ions such as potassium and hydrogen. Secretion of hydrogen ions is important in regulating the pH of body fluids. Potassium ions are secreted as sodium ions are reabsorbed in the distal tubules. This figure shows you the tubular secretion of potassium ions. The hormones aldosterone and cardiac natriuretic peptides affect solute concentration of urine, particularly sodium. The ability of kidneys to maintain the internal environment depends mainly on their ability to concentrate urine by reabsorbing large amounts of water. The distal tubule and collecting duct cells are impermeable to water in the absence of ADH, or antidiuretic hormone. So water may be excreted as dilute urine. If ADH is present, these segments become permeable, and water is reabsorbed by osmosis into hypertonic medullary interstitial fluid. Urine becomes very concentrated, and urine volume decreases. Although the majority of nephrons are cortical, juxtamedullary nephrons are more important in the regulation of water reabsorption. Okay, figure 20.23 shows you the effects of ADH on urine volume. And this shows you what happens under low ADH levels and high ADH levels. Table 20.2 shows you the role of ADH in regulating urine concentration and volume. The countercurrent multiplier. This mechanism in the nephron loops of the juxtamedullary nephrons keeps the medullary interstitial fluid hypertonic, so a concentrated urine is produced. Ascending and descending limbs of nephron loops are parallel and in close proximity to each other. The two limbs do work together. The thick ascending limb of the nephron loop is impermeable to water, but actively reabsorbs sodium and chloride ions. This results in hypertonic interstitial fluid and hypotonic tubular fluid in ascending limbs. In response, water in descending limbs leaves by osmosis, since it is permeable to water, but not to sodium and chloride ions. This results in hypertonic tubular fluid in the descending limb. The mechanism is called the countercurrent multiplier because every time the cycle is completed, the sodium chloride concentration in the ascending limb increases. The vasa recta of the juxtamedullary nephrons also have a countercurrent mechanism called the countercurrent exchanger, since no active transport occurs. This figure shows you the countercurrent multiplier. This figure shows you the countercurrent exchanger of the vasa recta. Figure 20.3 shows you the functions of the nephron components and the collecting duct. So this is a good summary for you. Let's talk about urea and uric acid excretion. So urea is a byproduct of amino acid catabolism. Plasma concentrations reflects the amount of protein in your diet. It enters renal tubules through the glomerular filtration and undergoes both tubular reabsorption and tubular secretion. Up to 80% is reabsorbed, and the rest is excreted in the urine. Uric acid. This is a product of nucleic acid metabolism. It enters the renal tubules through glomerular filtration. Active transport completely reabsorbs filtered uric acid. And about 10% of uric acid enters the urine through tubular secretion, and it's excreted. Excess uric acid may lead to painful conditions like gout, in which uric acid precipitates in blood and forms crystals in the joints. Urine composition reflects the volumes of water and solutes that the kidneys must excrete or conserve to maintain homeostasis. The composition of urine varies due to dietary intake and physical activity, but typically it consists of about 95% water, and it contains metabolic waste products like urea, uric acid, and creatinine. It contains small amounts of amino acids and varying amounts of electrolytes. Urine volume is about 0.6 to 2.5 liters per day. 50 to 60 milliliters of urine output per hour is normal. Volume varies with fluid intake, sweating, body temperature, emotional states, and environmental factors. Table 20.4 shows you the relative concentrations of plasma, glomerular filtrate, and urine components. In renal clearance, the rate at which a chemical is removed from the plasma by the kidney. The tests indicate kidney efficiency, glomerular damage, and progression of the renal disease. Renal clearance tests include inulin, a polysaccharide of some plant roots in the clearance test, creatinine clearance test also. And since these substances are both filtered by the glomerulus, but neither are reabsorbed nor secreted, tests of renal clearance are used to calculate the glomerular filtration rate. Okay, clinical application. Chronic kidney disease, chronic glomerulonephritis. This is inflammation of the glomerular capillaries. It's progressive and degenerative with no cure. Symptoms include hypertension, proteinuria, hematuria, dark urine, elevated blood levels of blood urea nitrogen, or BUN, creatinine, and decreased protein in the blood. It can lead to end-stage renal disease. Treatments include hemodialysis 3 times per week, or maybe a kidney transplant. Storage and elimination of urine. Urine forms throughout the nephrons and the collecting ducts, and then follows this pathway to the outside of the body. Through the openings into the renal papilla, it drains into the minor calyces, it drains into the larger major calyces, it drains into the renal pelvis, it follows the renal pelvis, which narrows to become the ureter, it's transported to the urinary bladder for storage, and then it leaves the body through the urethra. The ureters are tubular organs that are about 25 centimeters long, which transport urine from the kidneys to the urinary bladder. Each begins as a renal pelvis in the kidney. Each empties into the posterior portion of the urinary bladder in the pelvic cavity. The wall of the ureter consists of 3 layers: the inner mucus coat, or the mucosa, which consists of transitional epithelium, a middle muscular coat, or muscularis, and an outer fibrous coat, or adventitia. Peristaltic waves transport urine along the ureters. An obstruction, such as a kidney stone or renal calculus in a ureter, can cause strong peristaltic waves in the obstructed ureter to move the stone towards the urinary bladder. Ureterorenal reflex constricts the renal arterioles and decreases urine production in the affected kidney. Okay, this image shows you the cross-section of the ureter. Clinical applications: kidney stones. They can be composed of uric acid, calcium oxalate, calcium phosphate, or magnesium phosphate. They form in the collecting ducts or the renal pelvis of the kidneys. It causes severe pain, nausea, and vomiting, and blood in the urine. 60% of kidney stones pass on their own. Others can be shattered with lithotripsy or removed surgically. There's a tendency to form kidney stones in an inherited state, especially the calcium stones. The causes include calcium supplements in those with inherited tendencies, excess vitamin D, urinary tract blockage, and urinary tract infections. The urinary bladder. This is a hollow, distensible muscular organ in the pelvic cavity. It stores urine and transports it into the urethra. It contacts the anterior walls of the uterus and vagina in the female and lies posteriorly against the rectum in the male. The triangular trigon at the floor of the bladder contains openings at each of its 3 corners, 2 for the ureters and 1 for the urethra. The wall consists of 4 layers: an inner mucus coat called the mucosa, which is transitional epithelium, submucous coat or submucosa, a muscular coat, the muscularis, and an outer serous coat, we call the serosa, at the upper surface only. Smooth muscle fibers of the muscular coat comprise the detrusor muscle. The internal urethral sphincter surrounds the neck of the bladder. Figure 20.27 shows you the urinary bladder in females and males. Figure 20.28 shows you the male urinary bladder. 20.29 is a micrograph of the urinary bladder. The urethra is a tubular organ that conveys urine from the urinary bladder to the outside of the body. It has an innermost mucus coat, the mucosa, and a thick muscular coat, the muscularis. The internal urethral sphincter is a smooth muscle which is involuntary. The external urethral sphincter is skeletal muscle, and it is voluntary. The submucous coat, or the submucosa, has many mucus glands, called the urethral glands. The female urethra is about 4 centimeters long. The external urethral orifice is anterior to the vaginal opening. The male urethra is about 19.5 centimeters long and has a dual function for both urination and reproduction. There are 3 sections: the prostatic urethra, the membranous urethra, and the spongy urethra, which terminates at the external urethral orifice in the penis. Figure 20.30 shows you a cross-section through the urethra. Figure 20.31 shows you the urinary bladder in the female and the male. Micturition, or urination, is the expulsion of urine from the urinary bladder. Urine leaves the urinary bladder by micturition reflex. It occurs through a reflex contraction of the detrusor muscle and a reflex relaxation of the internal urethral sphincter. It requires relaxation of the external urethral sphincter, which is voluntary. The urinary bladder may hold as much as 600 milliliters. The urge to urinate starts when it contains about 150 milliliters. It's controlled by micturition reflex centers in the sacrospinal cord. There are problems sometimes with micturition, like incontinence, which is the inability to control micturition, and nocturnal enuresis, or bedwetting. Okay, the major events of micturition include the urinary bladder distending as it fills with urine. The stretch receptors in the bladder wall are stimulated, and they signal the micturition center in the sacrospinal cord. The parasympathetic nerve impulses travel to the detrusor muscle, which responds by contracting rhythmically. The need to urinate is perceived. Voluntary contraction of the external urethral sphincter and inhibition of the micturition reflex by impulses from the brainstem and the cerebral cortex prevent urination. Following the decision to urinate, the external urethral sphincter is relaxed, and impulses from the pons and hypothalamus facilitate the micturition reflex. The detrusor muscle contracts, the internal urethral sphincter relaxes, and urine is expelled through the urethra. The micturition reflex subsides. The detrusor muscle relaxes, the internal urethral sphincter contracts, and then the bladder begins to fill with urine again. Table 20.6 shows you the developmental abnormalities of the urinary system. Okay, urinalysis can be a clue to your health. It can be used to diagnose certain diseases or disorders and check for drug usage. For example, people with untreated diabetes mellitus have glucose in their urine. And there are several harmful inherited disorders that alter the urine color and sometimes viscosity. Some genetic conditions alter urine without causing harm. And beechuria, in which urine turns pink after eating beets, and urinary excretion of odoriferous components like asparagus. Lifespan changes. The urinary system has sufficient reserve in both structure and function to mask age-related changes. Kidneys become slower to remove nitrogenous waste and toxins and to compensate for changes that maintain homeostasis. So age-related changes include the kidneys appearing scarred and grainy due to connective tissue accumulation. Kidney cells die. By the age of 80, the kidneys have lost a third of their mass. Kidney shrinkage is due to the loss of glomeruli, and loss of surface area for filtration decreases the glomerular filtration rate to about half by age 75. Proteinuria may develop, renal tubules thicken, reabsorption of nutrients and ions become less efficient. It's harder for the kidneys to clear certain substances. Blood flow to the kidneys slows. The urinary bladder, ureters, and urethra lose elasticity. The bladder holds less urine. Kidneys are less able to activate vitamin D, and loss of bladder control may result in incontinence. And that's the end of the section on the urinary system.